So finally, we're going to talk a bit about how you diagnose preeclampsia and how you manage it. So all pregnant women, regardless of background or risk factors, should be having routine urine dipstick tests and blood pressure measurements at their antenatal appointments. If one of these urine dipsticks is positive for protein, or if any elevated blood pressure is detected in pregnancy, then that should prompt some investigation. So the initial investigations, you'll sometimes see these referred to as PET bloods. That stands for pre-eclamptic toxemia, and that's just an old term. Obviously, blood pressure needs to be done. That's one of the defining features. PCR, we talked about, is how we quantify the amount of protein in urine, because it can't be quantified accurately with a urine dip, and a 24-hour collection is time-consuming and a bit messy. A full blood count and LFTs will give us a baseline from which we can monitor any progression towards HELLP syndrome, as we mentioned before. Usinase will monitor for the renal complications of preeclampsia, because obviously we talked about how damage to the endothelium can lead to proteinuria and ultimately to renal failure. So that's how we monitor for that. INR is actually a measure of acute liver impairments, because it measures the synthetic function of the liver by assessing how well it's making clotting factors. So if we start to see deranged INR, then we know that potentially there's some liver damage, and it'll also help us monitor any coagulopathies that develop as a result of the endothelial dysfunction that we talked about. And then serum urea, uric acid, and creatinine are part of the way of assessing for any renal damage. So management, we need to monitor the maternal health and consider admission. We need to treat the hypertension, and we need to plan the birth. So the mother needs to be monitored regularly. Now this is case-based, it will vary from mother to mother, but generally speaking, the recommendations are that blood pressure needs to be done once every 48 hours. You want to monitor the bloods we talked about, to monitor for any kind of progression of preeclampsia towards symptomatic disease about twice per week. And you want to ultrasound the fetus every 2 weeks. And this is to assess for growth, because as we talked about before, intrauterine growth restriction is a common complication of preeclampsia. Obviously, the frequency of this monitoring will have to increase if the hypertension worsens. Now, considering admissions, this is to do with if symptoms or the parameters being measured worsen. Again, it's case-based and it depends on severity. And here are some severe features that might make you consider admitting a woman. So if the blood pressure rises above 160/110, if they start to develop a severe headache or nausea and vomiting, and these are signs of impending eclampsia, as we talked about way back in the presentation section. If she starts to develop epigastric pain, again, that's a sign of an impending HELLP syndrome this time, because that's a sign of liver involvement. And if any of the biochemical tests we're doing, like the FBC, like the LFTs, like the usinase, start to become deranged. So now for the part of preeclampsia you can actually treat, and that's the hypertension. It's different from treating hypertension outside of pregnancy. The first line drug here is labetalol, which is a beta blocker. Then second line is nifedipine, a calcium channel blocker. And if those don't work, then your third line is methyl dopa. You would also offer between 75 and 150 milligrams of aspirin from 12 weeks. And that's if at the booking appointment, more than one moderate risk factor is present. I wouldn't suggest memorizing exactly what qualifies as a mild or a moderate risk factor, but if you have a good idea of them in your head, and we talked about some earlier, if you want to go back and have a look at those. Considering early delivery. So this is a balancing act between the fetal and the maternal health, because the longer the pregnancy persists, the worse the preeclampsia will get and the more vulnerable the mother is. But if the fetus is delivered too early, then it's more at risk of a variety of complications associated with prematurity. If the fetus is going to be delivered early, then you need to give steroids to mature the fetal lungs. You also need to give magnesium, which has two benefits. One, it will protect the baby's brain in preterm birth, and this is given to all mothers in preterm labour. And two, it will actually protect the mother from eclampsia, as we talked about before. It's important when giving magnesium to remember that it's neurotoxic and overdose. So women receiving magnesium should be monitored once every 4 hours, and they need to have basic observations taken, and they need to have their deep tendon reflexes tested. And if you start to see a decrease in those reflexes, or say respiratory depression, then that's a sign that magnesium needs to be slowed because it's becoming neurotoxic. And then, as with many conditions, they need monitoring postnatally. Okay, thank you very much for listening to my talk. Here are some good articles if you want some further reading to fill in any gaps, and these should all be linked below. Thank you very much.